Hello, and welcome to today's webinar titled Lifestyle Medicine and Breast Cancer, Awareness to Action. For the next hour, you will be joined by three distinguished speakers, Drs. Nigel Brockton, Amy Commander, and Simran Malhotra, and myself, Melissa Habedank, as the moderator of today's webinar. I am the Senior Director of Strategic Health Initiatives and External Relations at the American Institute for Cancer Research. Now more than ever, during Breast Cancer Awareness Month, we are all excited to be here with you. Before I tell you more about today's webinar objectives and speakers, I wanted to briefly tell you about the American Institute for Cancer Research, where Dr. Nigel Brockton and I work. The American Institute for Cancer Research funds cutting-edge research and gives people practical tools and information to help them prevent and survive cancer. Our vision is to live in a world where no one develops a preventable cancer. Driving this vision is our mission: to champion the latest and most authoritative scientific research from around the world on cancer prevention and survival through diet, weight, and physical activity, so that we can help people make informed lifestyle choices to reduce their cancer risk. Moving along now to the reason you've joined us today, webinar objectives. After skin cancer, breast cancer is the most common cancer diagnosis in women in the United States. October is Breast Cancer Awareness Month and an opportunity for education and increased awareness of this disease, as well as a call to action. How can tools from lifestyle medicine reduce breast cancer risk? Here are the objectives for today's webinar in the order they will be presented. As you can see, by the end of this webinar, our speakers will have reviewed risk factors for breast cancer and the role of genetics, outlined the latest evidence regarding lifestyle factors and breast cancer risk reduction, and emphasized the importance of return to screening given delays during the pandemic. Now, let's talk about today's speakers. I'll do this in the order in which they will present. Dr. Simran Malhotra will review breast cancer risk factors and the role of genetics. She is a triple board certified physician in internal medicine, hospice and palliative care, and lifestyle medicine. She is currently the palliative care medical director at MedStar Harbor Hospital in Baltimore, Maryland. She serves as the co-chair of the American College for Lifestyle Medicine's ACLM's breast cancer subcommittee. She is also a previvor and BRCA1 mutation carrier with a strong family history of breast and female reproductive cancers, who underwent a risk-reducing bilateral mastectomy and total hysterectomy in 2020. Next, Dr. Nigel Brockton will outline the latest evidence regarding lifestyle factors in breast cancer risk reduction. He is Vice President of Research at the American Institute for Cancer Research. He earned his PhD in the genetic epidemiology of colorectal cancer risk from the University of Aberdeen in Scotland. After more than 2 decades as a cancer researcher, a 2-time cancer survivor, and a fervent cancer research advocate, he joined the American Institute for Cancer Research in 2017. There, he directs its research program spanning the cancer continuum through cancer prevention, treatment, and survivorship. He also serves as adjunct associate professor at the University of Calgary. Then, Dr. Amy Commander will emphasize the importance of returning to screening given delays during the COVID-19 pandemic. Dr. Commander is a breast oncologist at the Massachusetts General Hospital Cancer Center. She is Director of Breast Oncology and Cancer Survivorship at the Mass General Cancer Center in Waltham and at Newton Wellesley Hospital. She is co-medical director of the Mass General Cancer Center in Waltham and an instructor in medicine at Harvard Medical School. She received her undergraduate and master's degrees in neuroscience from Harvard University and her medical degree from Yale. Along with Dr. Malhotra, she serves as co-chair of ACLM's breast cancer subcommittee. Now, a few final things before we dive in. First, on behalf of the speakers and myself, we want to extend a huge thank you to ACLM for making this webinar possible. Second, a recording of this webinar with the slides will be made available to the public on ACLM's website. It will also be available on the American Institute for Cancer Research's website. And finally, the speakers will be available after the presentation for about 10 to 15 minutes of Q&A. So if you are attending live, please type your questions into the Q&A box, not the chat box, please. You can do this at any time, and you do not have to wait until the Q&A portion of the webinar to add your question. We will get to as many of your questions as possible. Now, without further ado, let's dive in. Dr. Malhotra, please take it away.
Thanks, Melissa, and a special thank you to ACLM and AICR for giving us the opportunity to speak on such an important topic, especially during Breast Cancer Awareness Month. And I will start by kicking off with some breast cancer facts. Can we get the next slide, please? All right, so in this figure, we can see the latest number of new breast cancer cases as well as deaths in the US this past year. Keep in mind that this figure excludes skin cancers. So if you look at the top right, you can see that in 2021, there will be over 280,000 new breast cancer cases diagnosed in females this year in the United States, making it the most common cancer diagnosed in women after skin cancer. Looking at the bottom right, you can also see that it's the second leading cause of cancer death in women after lung cancer. Next slide. So when we think about breast cancer, we often think about women, and we have to also remember that men can get breast cancer too, and about 1 out of every 100 breast cancers diagnosed in the United States is found in a man. Other things that to remember, cure rates have been improving, which is great news, and these improvements in outcome have resulted from treatment advances as well as earlier detection through screening. And later on in this talk, Dr. Commander is going to speak specifically to how screening was affected during the pandemic. Next slide. So I wanted to show this important slide. You can see on the right side, breast cancer is represented by the pink line. And what we can see here is that breast cancer incidence rates have continued to increase by about 0.5% per year. And this is thought to be, at least in part, due to continued declines in fertility rates, as well as increased body weight. Next slide. So here is a slide showing the non-modifiable risk factors for the CDC. So of course, the #1 risk factor for breast cancer is being female, and then followed by increasing age, with most women being diagnosed after the age of 50. Next, we have inherited genetic mutations, things like BRCA1 and 2, which put women at a higher lifetime risk of breast cancer, especially under the age of 40. I'll touch on more on genetic mutations and family history shortly. Other things to remember, a prior history of breast cancer, as well as atypical breast lesions like LCIS or atypical hyperplasia are important risk factors because they can increase breast cancer risk by up to 4 times. A prior history of thoracic radiation before the age of 40. So this is particularly important for women who have had radiation or treatment for diseases such as Hodgkin's lymphoma, which put them at a higher risk of breast cancer later in life. Increased breast density. So by definition, dense breasts have more connective tissue than fatty tissue. And this is important because this can sometimes make it hard to see tumors on mammogram. So while we aren't entirely sure why this is the case, women with dense breasts do have a higher chance of getting breast cancer. And typically younger women have denser breasts. This is a key distinction here is that it's particularly important for young women who also have genetic predispositions who need regular screening. And so in this population, they may also be offered additional screening modalities such as MRI. And then lastly, ethnic, race, as well as reproductive history. So menarche prior to the age of 12 or menopause after the age of 55 are also non-modifiable risk factors. Next slide, please. So this slide gives you a better idea of the correlation between age and risk of cancer. So on average, 1 in 8 women in the United States, which is about 12%, will develop invasive breast cancer over the course of their lifetime. And I think, again, that's the key distinction because we often hear the 1 in 8 number. And it's important to realize that that's over the course of a lifetime. And of course, this does not apply to women who carry genetic mutations. Next slide, please. So this is one of my favorite slides because most people, most women will attribute their cancer to their family history. However, what we can see, you see that 70 to 80%, so the pink part of this chart shows you that majority of breast cancers are actually sporadic in nature. And according to the CDC, the red piece of the pie there, only about 5 to 10% of all breast cancer cases are caused by hereditary mutations. With BRCA1 and 2 being the most common. So they account for about 50% of all hereditary breast cancers. And just a side note, BRCA1 and 2 are also associated with an increased risk of other cancers, such as ovarian, prostate, pancreatic, as well as melanoma. And just as a refresher, I've used the word BRCA many times now, and just as a refresher, everyone has BRCA genes, and they actually work as tumor suppressor genes. So they're very important in protecting us against cancer. So when they're working properly, these genes help keep breast and ovarian and other cell types from growing and dividing too rapidly and leading to cancer. And then, so lastly, you see the purple pie, part of this chart, 15 to 20% are associated with familial predispositions, which is probably a combination of environmental factors as well as low penetrance genes. And so just take kind of a mental picture of this slide, because later Dr. Brockton will go into detail about lifestyle-related risk factors and what we can do to reduce the risk of breast cancer, and that'll really apply to that 70 to 80% of sporadic cases. Next slide, please. So when should you think of hereditary breast cancer? So I just wanted to take a minute to talk about kind of the red flags. Family history, of course, is very important, along with any known genetic predispositions. A woman's risk of breast cancer is higher if she has a first-degree relative, for example, her mom, her sister, or her daughter who has had breast cancer, or multiple family members, either on the maternal or paternal side of the family, who have had either breast or ovarian cancer. Of course, having a first-degree male relative with breast cancer at any age increases risk as well. And then we also have to remember some of the higher risk population groups, such as the Ashkenazi Jewish population. Women of this descent carry a 1 in 40 chance of carrying one of these mutations. Just a final note on hereditary mutations. Aside from the BRCA1 and 2 mutations, there are numerous other moderate risk penetrance genes that can be tested for with current genetic testing panels. And I think an important point to remember is that not all genetic mutations are created equally. You have high penetrance genes that are associated with an 18 to 20-fold increased risk of breast cancer, and these include some of the ones I've already mentioned, BRCA1 and 2, others include TP53 and STK11. And then you have moderate penetrance genes, which carry a 2 to 5-fold increased risk. And examples of these are the ATM gene, CHEK2, and the PALB2 gene. Next slide, please. So this slide demonstrates all the modifiable risk factors and all the things that we can do to reduce our risk. I won't spend too much time here because Dr. Brockton is going to dive into this in detail, but some of these include alcohol, physical activity, tobacco use, breastfeeding when and if possible. A special note on postmenopausal obesity, and to know that postmenopausal obesity carries a 1.1 to 2-fold increased risk of breast cancer, as well as the risk of dying of breast cancer goes up by about 30%. And this is thought to be due to the increased estrogen production from adipose tissue. Reproductive history, so nulliparity or lower parity is associated with an increased risk, as well as older age, so greater than 30 at the first live birth. Next slide. So when you look at overall risk assessment, the number one thing to really remember to do is take a complete and comprehensive family history, including the maternal and the paternal side. Oftentimes we forget about the dad's side, and the questions to ask are who had cancer, what age were they diagnosed at, and what type of cancer did they have? And remember, risk increases with the number of affected relatives, the closeness of that relationship, and then again, the age at which the relative was first diagnosed. And then of course, any known genetic predispositions. Next, if appropriate, consider these women for genetic counseling or testing, or men. And next, if someone is found to have a genetic mutation, there's two priorities. Number one, have them talk to the medical team about appropriate screening as well as risk reducing strategies. And then number two, which is often forgotten, is routine screening for psychosocial distress, especially pre and post-operatively for women who are considering or opting for risk reducing surgeries. So we want to remember to refer to mental health or sexual health counseling as appropriate, as well as support groups. It's very important, and I'm speaking from personal experience here, to help these women find and build ways to improve their mental and emotional resilience. And some things that we can do are introduce them to positive psychology, yoga, meditation, journaling, and etc. And then a special consideration is for women of color. They only represent a very small number of hereditary breast cancers, and this may be an underestimation of the prevalence due to many factors, some of which include lack of screening, cultural stigma to cancer, incomplete family history due to immigration history, body image expectations, and then simply just not enough priority being placed on women's health. And so while it is important to increase awareness within these populations, within kind of the medical community, it's also very important to be aware of the cultural aspects that may affect these women. Number three here, you have breast cancer risk assessments, which I won't go into too much detail about, but what's important to know is that there are several risk prediction and assessment models out there, and they carry a lot of benefits, including educating a person about their risk, as well as providing guidance on screening and risk reducing strategies, but they do come with limitations. So that's the only thing to remember there. And then lastly, the role of lifestyle modifications. And this is where I will end my part of the presentation and kick it off to Dr. Brockton, who is going to take a deep dive into lifestyle modifications. Thank you.
Thank you, Dr. Malhotra. Now we will be moving along to Dr. Brockton. Dr. Brockton, you have the mic.
Thank you very much, and thank you very much to ACLM for inviting me to talk. Over the next little while, I'm going to talk about the evidence that relates to lifestyle factors and breast cancer risk and to some extent outcome. Next slide, please, Melissa. So AICR is the world's, and with our partners, World Cancer Research Fund, the world's leading authority on the links between diet, body weight, physical activity, and cancer prevention and survival. And we got this reputation, if you like, by looking at the entirety of the evidence. So we've all, particularly in the realm of lifestyle factors in cancer and any health outcome really, these research studies come out that one week tell you that something's good for you and the next week they tell you it's bad for you. And it leaves consumers and clinicians very confused about what is the latest evidence. So that's the other reason why we put in place this continuous update project to look at the entirety of the evidence. So if you go to the next slide. That's what the AICR WCRF put in place in 2007, having done the first expert report in 1997, when there was really very little evidence available, but what was available was put together and was actually, when you look back at it, was very much on the right track in terms of the recommendations it made. But this was very much formalized in 2007, with a whole process by which we collect and analyze and synthesize all this evidence. And I think of it as a funnel where we start off, get all the papers that have been published across all of these exposures. This has been done on a sort of cancer by cancer basis. The focus of this talk is obviously on breast cancer, but we've done it for 17 types of cancer. And in total, it covers 51 million people and 3.5 million cancer cases. So a pretty massive undertaking. The systematic literature reviews that this is really all based on are pretty massive and dense. I mean, the breast cancer one is 2,000 pages long. The CUP report that comes out of that, that's this, the nice colorful one, second from the left, is a sort of 200-page summary of the highlights of the systematic literature review and all the judgments from the expert panel. And then in 2018, we published the third expert report, which put all this together. And there's a nice 116-page summary, which has a very satisfying pullout in the back, which gives you all of the cancers, all of the cancers down the left and all the exposures along the top. So it's a really handy reference guide. You can print that off from our website, and you can actually order a hard copy of it as well. From all of that, we come up with recommendations. And do I have a slide? I have a slide later that shows the recommendations in more detail, but these are the pragmatic steps that people can take to reduce their cancer risk. Next slide, please, Melissa. So this is all that is in. When the first and second expert reports were published, they were basically sort of 400-500-page tomes. There was no way we could fit everything that's, with 20 years of evolving evidence into one item. So we have the printed report, and then there's all these other chapters available to be printed off from the website. And just to point out, that top line there is all the protocols. Everything starts with a protocol so that there's no kind of ad hoc retrospective fitting of things. You say what we're going to analyze, and then we do that and report the results. If there are exposures that you're particularly interested in that you don't see in the printed report or in the CUP reports, dig into the SLRs and you'll likely find whatever available evidence is in there. So how do we actually do this? How do we assess the evidence? Next slide, please. It's the first step is a systematic literature review where you collect all the evidence, and then if possible, we do linear dose response. So that's looking at, for a given amount of something, how big an effect does it have on your cancer risk? These are two examples actually for milk intake, which is quite a controversial topic in some areas. The evidence in breast shows us that it does not affect risk. And here's an example where a large study done in 2002 showed no risk, another one in 2009, and then a small one in 2013 showed that there was an increased risk in premenopausal, but then a corresponding decreased risk in postmenopausal. But both summary estimates are zero change in risk. Next slide, please. When we can, it's often more informative to do nonlinear dose responses. So does the curve of risk change? And this is for fiber, where you see the risk really starts to go down at a rate, well, becomes significant at 30 grams per day. Unfortunately, the average US adult only eats about 15 grams of fiber per day. So we often don't see, and this is, depending on where studies are done and what level of exposure people are getting, you wouldn't see an impact of fiber when it's done in intakes of less than 30 grams. But then you do see that protective effect at higher levels. Next slide, please. And these are called forest plots. So we see all the studies down the left-hand side, all the risk estimates on the right there, and graphically represented. Basically, if something is to the right of that line that's marked as 1, it's an increased risk, and if it's to the left of it, it's a decreased risk. This is for alcohol, which we'll talk about a bit later. And although this is a non-linear dose response curve, it's a pretty linear effect of alcohol on breast cancer. And that shows you that it just goes up from pretty much zero intake. Anything above that increases your risk significantly. Those dotted lines are the confidence intervals. Next slide, please. So when we put all this together, we put them into these what we call matrices, and strong evidence, and we have criteria for what represents strong evidence. And there's two categories of that: convincing and probable. Generally, convincing needs randomized control trial evidence. Not necessarily, but that definitely helps get above that convincing line. But probable is still very strong evidence. And then there are these factors in the limited suggestive where we think there's an effect, but there's sort of methodological or volume of evidence limitations. And then lots of other factors in these limited no conclusions where there's too much heterogeneity in the studies. So we really can't make a call on those. Next slide, please. And this is just the strong evidence ones for pre and postmenopausal breast cancer. And the ones with these sort of brackets beside them are pointing out the modifiable ones, because obviously adult attained height is not modifiable. And the mother can choose to breastfeed if she can, but as the offspring, you don't really have a choice. Okay, next slide, please. These are our recommendations. And as Karen Collins says so succinctly, this is a call for action, not perfection. Any changes, beneficial changes that you can make to your behaviors in these recommendations will reduce your risk of cancer. If you can do all of them, fantastic. But any changes that you can make will have a beneficial effect. So I'm now going to go through each of these recommendations, focusing really on the ones that relate to breast cancer, because some of them actually have the majority of their impact in, or a couple of them have the majority of their impact in colorectal cancer. But I'm going to go through them now. So next slide. Be a healthy weight. Keep your weight within the healthy range, and avoid weight gain in adult life. So this is based on the evidence. Next slide, please. Showing this consistent increased risk. The size of these diamonds in these and the squares that you saw in the previous forest plots represent the relative size of the population. So you can see an awful lot of evidence, an awful lot of the studies have been done in breast and colorectal cancer. And we see that one outlined, that's for postmenopausal breast cancer. There's about a 12% increased risk of postmenopausal breast cancer for every 5 points of BMI. So from 25 to 30, 35 to 40. 30, yeah. The interesting one is that, and really AICR back in 2018 were the first ones to finally kind of accept that this is a real effect, is that there's a decreased risk of premenopausal breast cancer with early adulthood obesity. We don't know exactly why. It's certainly not something that we would recommend as a public health measure to reduce your risk of premenopausal breast cancer, but it is a real biological effect. And it's tricky public health messaging. Next slide, please. The next one is to be physically active. Be physically active as part of everyday life, walk more and sit less. And this is based on the evidence, next slide, showing that both for pre and postmenopausal breast cancer, there's a reduced risk. You can see that to the left of that line that marks 1. Particularly in premenopausal breast cancer, the strongest evidence is for vigorous activity, and for postmenopausal, just total activity. I put these other cancers in just for sort of relativity and context. Physical activity is good, both for breast cancer and others. Next slide, please. So these are 4 recommendations, which the 2 on the left, particularly red meat, is red and processed meat really reduce the risk of colorectal cancer. There's been some evidence for an effect in breast cancer, but it doesn't reach that strong level where we'd make a specific recommendation. And eating diets rich in whole grains and vegetables, the strongest effect is actually seen in colorectal cancer and upper area digestive cancers. But typically people who eat higher amounts of vegetables and fruits and beans eat fewer calories. So obesity is the strongest risk factor for cancer beyond smoking. So that recommendation for breast cancer patients or for breast cancer is operating probably through obesity. Similarly, fast foods and processed foods, lots of research showing that people that eat processed food tend to eat more calories, and sugar sweetened drinks. So a lot of this is operating through the obesity pathway, rather than very specifically within breast cancer. But obesity is a strong risk factor for breast cancer. Next slide, please. So when we published the 2018 third expert report, part of that was this determinants of weight gain, overweight, and obesity. And if you go to the next slide, you can see a lot of these usual suspects in the convincing and probable, the strong evidence: sugar sweetened drinks, fast foods, Western type diet as increasing your risk, and things like physical activity and Mediterranean diet and foods containing fiber reducing your risk of obesity, but obviously they then have a knock-on effect on breast cancer risk. Next slide, please. Next recommendation, and always one that causes a lot of discussion, is to limit alcohol consumption. For cancer prevention, it's best not to drink. And if you go to the next slide, unfortunately, if you're a drinker, it doesn't matter what you drink. Whether it's beer, wine, spirits, they all increase your risk of both pre- and postmenopausal breast cancer. So yeah, the health halo that exists around wine is not deserved. You may choose to drink, but then drink within the national guidelines, and certainly avoid everyday drinking. Next slide, please. Do not take supplements for cancer prevention. So over the years, I started my PhD in 1997 with a big focus on folate metabolism. We've all seen the beta carotene studies. There's been so much quest for the magic bullet in cancer, and they don't work. There are reasons to take supplements, but cancer prevention is not one of them. Next slide, please. For mothers, breastfeed your baby if you can. It's good for the mother and it's good for the baby. There is a statistically significant reduced risk for reducing breast cancer risk for 6 months and up to 2 years. So it's good for the mother and baby. This aligns with the WHO recommendation. So we certainly support that. Next slide, please. After a cancer diagnosis, follow recommendations if you can. So we don't yet have specific recommendations for cancer survivors. And one of the reasons for that, if you click to the next slide, is we did an analysis back in 2014 looking at the evidence for lifestyle factors on certain survival outcomes, survival, so overall survival, breast cancer specific survival, and recurrence. And we didn't find any factor for which the evidence reached the convincing or probable, so that strong evidence bar. A few things in the limited suggestive, physical activity, foods containing fiber, foods containing soy, body fatness for increasing your risk, total fat and saturated fat. But these were still not quite reaching that bar. So we've actually just done another analysis with another, well, the cutoff was end of 2018. So another 5 to 7 years of evidence accumulated. Those will be, and I think the next slide just says coming soon. The papers are written, so these are going to come out as papers rather than the cut reports of the past. And I'm sure they're going to create a lot of discussion. We do have some firmer conclusions on some, but frustratingly, the evidence is still, if we're going to make recommendations, we need to be absolutely sure that they're correct. And whilst people always say, well, there's evidence for X, Y, Z, there's always evidence, and there's always evidence, you know, for and against. And we want to make sure that we're giving people the best possible advice. Next slide, please. For those of you not familiar with AICR, I encourage you to go to the website and have a look at the resources that we have. Lots of good, useful information in there. And next slide, please. And you can also check out the cancer health check. It's a really nice little tool just to check your adherence to the cancer prevention recommendations. The Healthy 10 Challenge is a 10-week challenge to help you meet those recommendations better. And the Coping with Cancer in the Kitchen program is a nutritional education program, but it covers psychosocial, and this is actually being rolled out to multiple centers now that we've done pilot studies and actually a randomized control of its effectiveness. So I will end there and hand over.
Thank you, Dr. Brockton. Next, we'll be hearing from Dr. Commander. Dr. Commander, you have the floor.
Great, thank you so much. And I'd like to echo the comments. Thank you to the ACLM for providing us with the opportunity to discuss this important topic during Breast Cancer Awareness Month. Next slide. So many of you are familiar with the benefits of screening mammography, but we felt that it was very important to include this topic in this talk. As you all know, the majority of breast cancers diagnosed in the United States occur after a woman has undergone a screening study. Screening mammography both reduces the odds of dying from breast cancer and facilitates use of early treatment. It should be noted that breast cancer mortality has decreased since the 1980s due to earlier detection through screening, as well as significant improvements in treatments for breast cancer. Next slide. This slide illustrates the age-adjusted US breast cancer mortality rates per 100,000 women for women aged 40 to 84 years from 1969 through 2015. And as you can see on this slide, mammography was introduced in the 1980s. And since that time, there has been a 42% reduction in breast cancer mortality. That has led to 384,000 to 614,500 lives saved, which is really impressive, all due to earlier detection and advances in treatment for breast cancer. Next slide. There have been numerous studies which have demonstrated the benefits of screening mammography. One study in particular by Tabar and colleagues looked at a large population registry in Sweden, which illustrated the benefit of women who chose to participate in organized breast cancer screening. And in this study, they showed that those women who chose to participate in a screening program had a 60% lower risk of dying from breast cancer within 10 years after diagnosis. and a 47% lower risk of dying from breast cancer within 20 years after diagnosis. Furthermore, those women with a screen-detected cancer required less extensive chemotherapy, less extensive surgery, and chemotherapy was shown to be more effective for those women who had undergone screening as compared to the group of women who chose not to participate in screening. Next slide. As my colleague Dr. Malhotra outlined in the earlier part of this talk, it is very important for women to discuss with their doctor specific risk factors such as family history and the other risk factors that she beautifully outlined. And understanding an individual woman's risk factors really are important for guiding shared decision-making when it comes to screening. For women who are above average risk for development of breast cancer, there are risk assessment tools which can be helpful decision aids and also inform whether breast MRI screening should be incorporated into a women's screening program. Various organizations have also outlined screening guidelines for breast cancer. Next slide. This slide, taken from the CDC, is a busy slide because it illustrates the various different organizations and what the recommendations have been for screening mammography for women aged 40 to 49 years with average risk, as well as for women aged 50 to 74 years with average risk. And as you can see, there are some differences between these various organizations, including the US Preventive Services Task Force, the American Cancer Society, American College of Obstetrics and Gynecologists, and other organizations outlined here. Please go to the next slide. I think what it's important to recognize that for women age 40 and above, it is important for healthcare providers to discuss individual risks and benefits of screening mammography, including options to begin at age 40, age 45 or 50, and whether or not to screen annually or biannually. For women ages 45 or 50 to 55, in general, mammography should be done every 1 to 2 years. For women aged 55 to 74, mammography at least every 2 years. And then for women 75 and above, it is important for a healthcare provider to discuss that individual's risk benefit for proceeding with screening, and screening may be beneficial for older women with a 10+ year life expectancy. Next slide. Now it's really important to focus on what has happened with breast cancer screening during the COVID-19 pandemic. As you know, the COVID-19 pandemic has created great disruptions in cancer screening for all types of cancer. Just as a review, on March 13th, 2020, the US government declared a national emergency to halt the spread of COVID-19. At that time, the CDC recommended that healthcare systems prioritize urgent visits and delay non-essential care, including cancer screening and some treatments for breast cancer. Thus, clinically recommended age-appropriate cancer screening tests, such as mammography, were not available. By the spring of 2020, screening for breast cancer had declined by 91%. It should also be noted that the COVID-19 pandemic has created loss of employment, loss of employer-sponsored health insurance, which has further contributed to a decline in adherence to screening. Next slide. So this slide was taken from data from the Epic Health Research Network, which has data from 60 healthcare organizations representing over 300 hospitals that span 28 states and covers 9.8 million patients. And as you can see on this slide, the number of cancer screenings completed each week in 2020 is compared to the expected number of screenings for equivalent weeks from 2017 until January 2020. As illustrated in the top panel, there was a 94% decline in breast cancer screening during this time period. In the middle panel, you see that there was also an 86% decline in screening for colon cancer and a significant decline in screening for cervical cancer as well. Why is this concerning? Well, we're worried that the delay in diagnoses may lead to presentations at more advanced stages and worse clinical outcomes. Next slide. This slide further illustrates the significant decline in newly identified patients with the 6 most common types of cancer, both before and during the COVID-19 pandemic. And if you focus on the columns that reflect breast cancer, as you can see, during those spring months of 2020, there was a very significant decline in new breast cancer diagnoses during that time frame. Again, we're worried that our patients are going to be presenting with more advanced stages and unfortunately may have a worse clinical outcome. Next slide. It's important to note that while we're now up and running again with mammographic screening and other types of cancer screening, when we look at breast cancer screening rates, we are still lagging behind where we want to be. Again, this slide is taken from data from the Epic Health Research Network and demonstrating that in 2021, there's still a significant decline in mammography screening rates by about 13% compared to the historical average. Next slide. The American Cancer Society has really taken it upon themselves to address these concerns regarding cancer screening. And they have a campaign ongoing right now to really raise awareness about the system and social challenges that we must address in order to increase screening rates for breast cancer and other cancers. And certainly there are many challenges as outlined on this slide taken from the American Cancer Society. There are challenges with new systems that are now in place and protocols given the pandemic. We have to address patients' fears and reluctance to go to the hospital for a screening test. Certainly, there's concern about decreased capacity for our primary care colleagues. And as I mentioned earlier, there's concern about loss of employment and employer-sponsored health insurance, as well as we've seen in the course of this pandemic, unfortunately, exacerbation of longstanding health inequities when it comes to looking at individuals of different races, economically disadvantaged individuals, and access to care. Next slide. So the American Cancer Society public awareness campaign to get screened really is trying to address each of these concerns in order to raise awareness and encourage action to increase cancer screening rates. And a number of strategies are outlined here, including how can we reach the unscreened and encourage individuals to come to the hospital and get their screening mammogram. We want to support adherence for regular screening and really try to address the disparities that have been seen in cancer screening across groups of people who have experienced greater social or economic obstacles to screening based on their racial or ethnic group, sexual orientation, education, health insurance status, immigration status, etc. It's very important to address the barriers to screening that were outlined on the previous slide. Specifically, how can we best address the fear of coming in for the tests, procrastination, lack of insurance, lack of symptoms, etc. So we hope after this presentation, you will encourage your patients to get their screening mammogram.
Thank you, Dr. Commander. This concludes the presentation portion of today's webinar. The Q&A portion will begin soon. If you would like to contact any of today's speakers, please do so using the email addresses on your screen. As a reminder, anyone can access a recording of this webinar with the slides on both BCLM's website as well as on the American Institute for Cancer Research's website. If you liked today's presentations and would like to learn more about diet, obesity, and physical activity as they relate to cancer, please consider registering for the American Institute for Cancer Research's virtual conference taking place from November 1st through the 3rd, 2021. It will feature talks from world-renowned scientists in the field of lifestyle and cancer research about the progress we have made in the field so far and what we have to look forward to in the future. The link to learn more and register is under Dr. Brockton's email address. Now we'll begin the Q&A portion of today's webinar. Thank you to those who have submitted questions. Here to moderate the Q&A is Leslie Casey, Senior Director of Marketing at ACLM. Leslie, take it away.